The next slide. These are our personal services. So we have, like I said, 13 positions that are in the account. I mean, these are net positions because, you know, people transfer and there are some vacancies here and there. And so for health information technology, there's 342,000, which represents 32%. For the healthcare benchmark initiative, there's 149,000, 14%. Health equity, 97,000 for 9%. Certificate in need, 66,000 for 6%, and our administration, 421,000 for 39%. And you can see the fund distribution in the depiction next to it. Next slide. And here we have presented the summary of our positions in the insurance fund over time. So as you know, we are established in 2018, 2019 OHS. We brought together 3 different teams from the Department of Public Health, Department of Insurance, and Healthcare Advocate. So there are a transfer of 6 positions. And in 2019, there were 9 positions. The 3 were also transferred in 2019 from the Office of Healthcare Advocate for the State Innovation Model Project. Fiscal year 2020 and 21, we completed the transfer of another position from the Office of Healthcare Advocate to OHS. This person conducts consumer engagement, represented OHS on advisory boards, and led us in partnership initiatives. And then for the next 3 years, we had a pretty steady 10 positions that were funded in the insurance fund. And then in 2024 and 2025, 3 positions were added to the budget. 1 position for the statewide health IT plan, 2 positions to enhance data analytic capacity. And those were in our budget as well. So again, it goes to fiscal year 24 and 25 have been 13 positions. 4 positions that were from unrealized policy goals are going to be returned via technical adjustment. Next slide, please. And then I'm just going to talk a little bit about the work streams in terms of the impact to the insurance fund. And overall, you know, the agency focuses on cost drivers, reducing costs, improving access, improving equity, looking at disparities. So all of these work streams really align together. But for the most part, as you can see, 80% of the funding in the insurance fund is the health information exchange, which I think, as all of you know as well, is an investment that the state made to, you know, support care coordination. It has real-time secure access to patient health information. You know, we now have 374,000 weekly encounters from 2,900 connected organizations. We're very proud of that. This year, we've added behavioral health providers as well. And I say it reduces costs associated with preventable readmissions, duplicative testing, and medical errors. It also supports public health and population health analytics. Next slide. And kind of tangential to that, and you see the Connecticut general statutes there, which we now have the Health Information Technology Advisory Council, HITECH, which provides policy recommendations for the HIE and the HIT initiatives. We also have the Health Insurance Exchange Regulations Subcommittee, Health Insurance Exchange Recommendations Work Group, which just came through Public Act 2410 this year. This group is going to be advising the HIE Regulations Subcommittee and providing feedback to the group as they move forward with regulations. And then you have the annual report of the State Health IT and Health Information Exchange. Next slide. The next strategic work stream that the insurance fund supports is the Healthcare Benchmarks Initiative. Also under statutory mandate, we set an annual healthcare cost growth benchmark and primary care spending target. We develop healthcare quality benchmarks. We develop strategies in consultation with stakeholders to meet these benchmarks. We monitor ACOs and PCMHs, accountable care organizations, patient-centered medical homes, and alternative payment models. It supports public health and population health analytics. It enhances transparency of $36.4 billion in total health expenditures. And we develop data dashboards and we provide public information on these healthcare cost growth factors, hospital prices, and prescription drug prices. And as you can see in the depiction here, per capita spending growth, as came out in our second report this year, shows that Connecticut has a 3.4%, which is a little bit above the 3.2% benchmark.
And you can also see how other states.
Next slide. This is the strategic work stream for the Connecticut, for our healthcare quality benchmark. We produced our first report this year, and it actually shows that payer performance is actually improved on these measures. And so we look forward to seeing what the next report is going to say, but we are very proud that they are meeting the quality benchmarks. And then the Connecticut's primary care spending target for state primary care spend for 2022, you can see it was 4.9%. The commercial 4%, Medicare 3%, Medicaid actually met the target, above the target, which is set at 5.3%. And our hope is at OHS to continue with these primary care efforts, therefore to reach a target of 2025, 10%. And that was my last slide. We are available for any questions.
Thank you very much. Sean King.
Good morning, Representative Wood, Representative Walker, Senator Austin, members of the working group. Again, my name is Sean King. I'm the acting healthcare advocate for the state of Connecticut. The Office of the Healthcare Advocate is Connecticut's managed care ombuds program. We are consumer assistants, consumer advocates on behalf of all Connecticut residents who are members of their health plans or seeking to become members of health plans. That goes for any member of a commercial health plan, whether it's fully insured, self-insured, as well as public plans, beneficiaries of Medicaid, Medicare. We're there to help educate and help advocate on behalf of those consumers in situations where they may simply have questions. Healthcare and health insurance is a complicated subject, and many people come to us with questions about how to enroll in a plan, how to choose their best plan, how to troubleshoot problems when they're trying to get access to services, how to pay for services. When they're faced with denials from their insurance company, we're there to help. We can intervene as their appointed representatives and help navigate them through a somewhat complicated administrative appeal process that is available to all members of health plans. We help them work through coordination of benefit issues, billing disputes with providers, access issues when maybe they don't have a network provider that can provide services. So our staff is there to help, again, any Connecticut resident faced with these problems, to educate them and help them resolve those issues. Our spend in fiscal year 24 that just ended was $3.2 million. Most of that was salaries and benefits. That was $2.9 million. We also leased some space down on Market Street. That runs about $100,000 a year. And then the remaining about $250,000 goes to utilities, IT services, things like that, as well as a small marketing and outreach budget that we use, again, to make sure that we're connecting with as many Connecticut residents as we can so they know about our services, and to, again, further that education about how to get on a health plan, understand their health plan, you can best utilize their health plans. The salary and benefit line staffs 18 positions, including the healthcare advocate, attorneys, paralegals, nurse consultants, and consumer information reps, all who have slightly different functions in our office, but are ultimately all there to advocate, manage cases that come in and do that advocacy work on behalf of your constituents and all the residents of Connecticut. We're very proud of the return on that investment that we provide to Connecticut residents. In fiscal year 2024, we returned $5.3 million to the pockets of Connecticut consumers through overturned denials. So, for example, if somebody was trying to get a surgery that was, cost about $20,000 and their insurance company denied it, but we were able to get that denial overturned. We're happy to say that we were able to return that $20,000 to the consumer's pocket. So, and that just includes our measurable results. We don't have necessarily a metric for how to count potential cost savings that people might have when we're able to answer a question, when we're able to guide them on how to pick a lower cost provider to get a service they're looking for instead of going to a hospital or health system type of service. So we're very proud of that return on our investment. Handling our staff handle last year over 5,600 of these cases that are referred to us through the insurance company's denial letters, through legislators' offices and their aides, and other sources. So we get our referrals from a variety of different places. And all of our staff, we have a great staff that have been with us for a long time, are well educated on the issues that come to our office, and are able to help those constituents. With that, I will be happy to take any questions that you have.
Great, thank you. I'm gonna do some questioning first. If you have questions, just let me know and I will add you to the list. And online, just please raise your hand. Great. First, I just want to do a kind of history. So the insurance fund was started in 1991, primarily to fund the insurance department, which makes sense because they're regulators and they're, overseeing the industry. I was looking kind of at the history of the insurance fund, and it seems to have three components. One is funding for state agency operations and staff. Another component is funding for various grant programs to private entities. Another is funding for statewide purchases of vaccines, which again, we'll talk about in a future meeting. And then a fourth component was added recently regarding the Healthy Homes Fund. So I kind of want to dive into this as, what the history of the fund was set up for and where we are today. And I want to ask my first question to OPM, which is, it looks like the grant programs under DPH were kind of transferred to the insurance fund during deficit years. And I understand that because you're looking for ways to, keep those grants going. But does it make sense in times of an economic surplus to keep those, funding through the insurance fund when they should be funded through the general fund?
Representative Walker, Representative Wood, sorry about that. So OPM specifically has 3 positions that are funded at OPM. I'm not sure about what is funded at DPH and the details of the positions funded at DPH, but OPM has 3 positions, and that I had highlighted earlier. Those 3 positions supports the insurance industry as it relates to long-term care and healthcare statewide.
I was more asking the question, is OPM's role as, the budgetary group of the state budget, was that something that OPM looked at, was the history of these grant programs and potentially moving them out of the insurance fund? Did that ever come up in discussions?
I will not know that answer, so I can absolutely get a response and get back to you on that.
I want to dive into the tobacco and health trust fund support position at OPM. How is that related to insurance?
The staff provide staffing support. So if there is any administrative need to have staff at the meetings to help coordinate meetings, that's the role of the OPM staff.
And again, just really related to insurance, how?
Well, the Tobacco Trust Fund, I believe is related, maybe not directly, but there is a relationship there. So as far as Health and Human Services is concerned, these 3 positions are in our Policy and Planning Division for all things Health and Human Services, therefore providing support. And that's not the only support they provide, by the way. The Insurance Fund and then Behavioral Health Committees that they sit on too and provide any staffing support that's needed.
I agree. I think they are related to Health and Human Services. I just am missing the connect on, insurance, but they're being covered through the insurance fund. I was wondering if we can move to OHS and go back to a slide on the goals of OHS. I think it was the first or second slide.
The key impacts, that one?
Next slide. Try the next one, please. Yes, right there. Great. I was wondering if you could show us how the dollars that are being achieved through the insurance fund, just a high level of how we're doing in achieving the goals of OHS that we have up here, which is controlling healthcare cost growth, enhancing healthcare quality. I mean, there's a lot to this question, but if you can high level talk to us about how the fund dollars are used to achieve these goals.
Okay, did you want me to enhance more my response on these other slides?
Yeah, that would be great. Just, we don't have to dive. I know there's a
Okay.
lot to that question,
Yeah.
but just, I'm trying to do kind of an overview of how the history of the fund for people that are watching and how those dollars are being used to achieve OHS's goals.
Sure. So specifically with the healthcare benchmark, I mean, really, as well as the Health Information Exchange, which are funded by the insurance fund. Each one of them hits all of these key impacts. You know, everything that OHS, all of our core functions and our initiatives, many are cross-cutting across the entire agency. And therefore, you know, the funds that are used for really many of our initiatives impact insurers. You know, so with the benchmark, when we're setting targets, spending targets, primary care targets, quality benchmarks, all of those initiatives lead to reduced costs, right? And when we are identifying cost drivers, whether they be pharmaceuticals or hospital outpatient growth, we're trying to focus on that so that everyone comes to the table and we can actually make a difference in reducing healthcare costs for the residents of the state. And then the Health Information Exchange allows consumers to make effective healthcare decisions. It promotes patient-centered care. It improves quality, safety, value of healthcare, reduces health waste, duplication of service, supports clinical decision-making, keeps confidential health information secure, and it's really making progress toward our public health goals. So we feel they're very important in those two initiatives.
And just to highlight for everyone, you did say 80% of that 13.7 million is for the HIE, correct?
That is correct.
Yeah, that's something that I learned today. That's a really big number. Do you have a history of the funds from the insurance fund dollars from OHS over time? I was wondering like where it started and where it is today. Is it like an exponential increase year over year? Is it a steady increase? Is it something that's plateaued, or is there a peak that's caused, like maybe the benchmark, putting that into place may have caused a spike?
You know, are we looking at personnel? If you want to go back to that or move forward to one additional slide, if you don't mind. So this one right here. So this shows the expenses over time. So here's the personnel and the other. So with the personnel services, you see spikes, like I said, because of some step increases and cold increases in staff. And then there's 3 positions that were added on in 2024 via the budget for data analytics, really to focus on cost growth benchmark as well as the HIE. And then also during that time, there was a transfer, and that's like the largest increase that I think I saw this morning in a report, is the increase. There was a transfer of 8 positions for the HIE from the general fund to the insurance fund. So that, you know, was a decision obviously that was made between the executive branch negotiating with the legislative branch over the budget, but that did occur. So that was the largest increase in personnel services, obviously, which also affected other expenses.
I did want to ask about the behavioral health advocate, and I was hoping OPM as kind of the budgetary office would be able to answer these questions, but I'll just put it out there. So that office was created, it directly affects the insurance fund, but that bill and the creation of that did not go through the insurance committee. And many of us on the committee, we think, you know, a lot of these things are created with wonderful intentions. I mean, who doesn't want to have to go to an advocate to work on behalf of them? Yet that was created, and then the insurance fund really assesses the people that we're trying to help by causing costs to raise. So I was wondering what the reasoning for creating a behavioral health advocate and then putting that cost onto our already very stressed, fully insured market, which would cause their premiums to go up? Like what was the reasoning for, adding that onto the insurance fund rather than paying for it out of the general fund?
Yeah, thank you, Representative Wood. I can briefly say that this budget was also approved by the legislature, so I don't have the specifics on why, but it was approved.
I was very vocal in saying that we shouldn't just be, tacking on assessments and making people's health insurance, premiums go up to create things like this. It should be paid out of the general fund. I'm just going to leave that comment there, and I will go to Senator Austin.
Thank you. I'm going to focus directly on the Office of the Healthcare Strategy. First, I'm going to say the Office of Healthcare Advocate, phenomenal. The work you do is beyond compare. I've had many constituents that I've referred to your group. They are able to resolve issues relative to many people's concerns. So I can't say enough good things about what you do with a very small amount of people, and always seem to be able to find a solution to a problem. So thank you.
Thank you, Senator Austin. I appreciate those kind words. I'm sure we can always do better, but I'm happy to hear that.
Thank you.
Comments. Thank you.
And so the Office of the Healthcare Strategy, can we take that slide deck down so that I don't think we need it. Thank you, Allison. Your main focus is to drive down healthcare costs, correct?
One of our main, but yes,
That's the top one on your list,
yes,
drive down healthcare costs.
yes.
And Representative Walker and I have had many discussions about the Office of Healthcare Strategy. And most recently, you had an audit done of the group that was just
Yes.
awful. And it was directly reflective of not really monitoring the dollars that you get over there. And we take that personal, and we take it, we find it to be an extremely bad sign of what's going on there. But you have continually each year asked for more staffing, and that staffing would not drive down healthcare costs. That staffing would drive healthcare costs up because it's paid out of the insurance fund, which directly assesses, the costs of all of these programs that we're handling today, the Office of Healthcare Advocate, the costs in OPM, the costs of the healthcare strategies. And you started out in 2019 at $2.8 million. And now you're up to $13.7 million. And if we had approved adding in what you had asked for, you would be double that right now. That's what you would be. And we find out this year that the monies that you have, you're not handling correctly, or not with the fiduciary responsibilities that we expect from every state agency. And I just don't understand, if the main focus of healthcare strategies is to drive down costs of healthcare, why you would want us to add in another $13 million or so. And, next year in the budgetary time frame, I'm certain that you're going to be asked, how does this drive down healthcare costs? And I don't see it. And this was starting in 2019. Yes, we were in bad times. However, you're one of the newest groups that were added in to the insurance fund. And I'm failing to see the value of a group that is not driving down healthcare costs, is not managing the dollars correctly, and is coming, you know, I know that Representative Walker talked about the fact that we've got a comprehensive slide deck, which we appreciate. We like data. But to get it that day without having the ability to have the Office of Fiscal Analysis look at what you gave us that's important for us. We take the independent, nonpartisan group of the Office of Fiscal Analysis as an important component of the legislature. And so I just don't see the value of what you're presenting here as dealing with the issue of the insurance fund overall. And if it was a state agency and you said that you wanted this, you know, I think some of this has to go back to the general fund so that we can start driving some of the costs down. Now, I know we added it all in. So it's not on OPM. You know, I'd like to place blame where blame is, and blame's with us. I know which bill put in the Office of Behavioral Health Advocate. I know which bill put it in. I know it was a Senate bill. I also know that it had the support of everybody in the Senate. And so we all saw value of it. I think that bill passed with both Republican and Democratic support for that. But we have the costs on here, but we've never filled the positions. So right now we're assessing the cost of something that we've not filled the positions on. And that's not on you or any of you that are here today. So we might be able to blame OPM for that, but not the two people that sit in front of us. So it's beyond their capacity. But the Office of Healthcare Strategy, I don't see it. I'm disappointed, very disappointed that, you know, we protect our state agencies. We want to protect our state agencies. But I don't see the value of $13 million on this right now, and see how we're getting to the main point of delivering on decreasing costs of healthcare. I mean, when we go to an insurance rate case, makes all the papers. Whether it's, we all know that healthcare costs have gone up 5%, 6% a year or more. We all know that property costs, insurance costs have gone up every year. I had somebody come to me on their car insurance saying, had no accidents in my whole time, yet my car insurance doubled. And that's a problem for people. So this is very much similar to the energy costs, where we have added in on the legislative side some things, but when we add them in, we want value back. We think some of these programs have great value, that we want to do that. I just don't see it on the healthcare strategy, how we're going to get to explaining that we're putting, we started off with 2.8 million and now we're at 13.7 million. So it's a little bit problematic, I think. So I'm hoping that you could send us some information that will show that this is a trajectory, and you're going to see a way into diving down into the costs and cutting those costs. So that's what I would like to see. If you could go back, come back with a PowerPoint on how this, because you may say this is on the upward trajectory, but in 2 years we're going to come back to you and be able to drive down the costs of healthcare for people. So thank you very much.
Any questions? Thank you. Representative Walker.
I just want to,
Representative Walker is going to yield to Tammy Nuccio, and then she'll pick up.
Thank you very much. And thank you for those presentations. I want to echo Kathy on one thing for sure. And everybody knows I'm a numbers person, I'm a data person, and I think OHA is actually kind of a model for us here. When you have a $3.2 million budget, but you can adequately show $5.3 million in savings for the people of the state of Connecticut, I would say your area is worth the money, right? I think the data that you have shown proves that the spend in OHA is definitely a good spend. I do have two small questions though that I think would just kind of help firm that picture up. Do you happen to know how many encounters you have in a year? And also, do you have a backlog? Like how quickly are things responded to in OHA?
Representative Nuccio, thank you also for your comments as well. To answer your question, our per year, so last year we had 5,677 cases or encounters as you described them. And that is a little bit above what we had seen in previous years. And I can explain why I think that's the case a little further if you're curious. And then I apologize, I lost your second question.
The second question is, do you guys have a backlog, or are you answering exactly as you get them?
We're just, because of that increase in cases, we're just a little bit slower. We pride ourselves on responding to consumer inquiries within 24 to 48 hours of receiving one. Every so often that might be 72 hours that we respond to an initial inquiry, but I wouldn't describe it as a backlog. It's just a little bit slower in pace at the outset, but otherwise our case managers are doing great work in handling the cases that come to them and moving them along in a timely fashion.
Well, I have to say, for all the state organizations that I talk to, if you tell me you have a 24 to 48 hour turnaround time, I think the entire state of Connecticut should model their businesses after you guys. So thank you for the encounters. That is helpful. It shows that, these are large dollar claims that you're able to mediate for our residents, and the $3.2 million again is probably one of the best spends that I think that we're spending in this area. I would like to ask OPM a couple of questions. In reviewing the positions that you mentioned, I do have some concern about a couple. The Connecticut Partnership Plan is not really an insurance plan. It is a state benefits plan. So I wouldn't expect to pay for Sean Scanlon's people who are administering the state of Connecticut's plan. I'm wondering what exactly the partnership plan is doing that I should have 3.6 million people paying for it outside of the comptroller's area, which handles state employee benefits and this partnership plan.
Thank you, Representative Nuccio. So OPM has these three positions, and the budget is about 600,000. The Connecticut Partnership for Long-Term Care, it is estimated that there's been over $131 million in savings to the state's Medicaid program. So what the partnership does is it supports, it helps with private insurers. It helps educate Connecticut residents about long-term care planning and provides an innovative funding model for them. And as I said, there's been over $131 million in savings.
I'm sorry, I wrote them down separately. You had Connecticut Partnership, I thought you said, and then Long-Term Care Coordination. So that's the Connecticut Partnership for Long-Term Care. It's one thing?
Yes.
Okay, then I take back my question. That makes more sense than I thought they were separate entities. I do have to agree with Representative Wood on the tobacco fund. Doesn't seem to make sense to be here. That is an award settlement that, the state gets to then administer out for tobacco cessation and stuff like that. I don't really see that one as being insurance driven. And the behavioral health policy, I understand that, but that's outside of the the positions that Rep Wood was asking about, correct? This is just specifically an OPM position for behavioral health policy. I don't like to me, when you say policy, I say general budget, right? That's not something that we should have insurance people paying for the state of Connecticut to come up with policy, right? In my opinion, but can you tell me a little bit more about what exactly that role is doing?
I'm gonna tag in here.
Can you just
for-
introduce yourself for everyone?
Sure. Zani Matowski. Just a little bit on the Tobacco Health Trust Fund. The reason why that relates to the insurance fund, it works on population health, right? Reducing health insurance costs overall. So that is a key part in this. I think a lot of people benefit from that. So I just want to make sure that gets clear, the nexus between those two. So
Well, I would argue though, right, that would assume that we were actually using the tobacco fund money for tobacco. Like it goes to the general fund in general. We've had what, 1 year now that we've actually put 10 or 12, $20 million in it, and the rest of it just got pulled out of the last budget adjustments. So it's not actually going to tobacco cessation at all. It's going to the general fund. So again, I do not see the tobacco fund here. If the money is going to continually for the last 30 plus years be used for the general fund, it should be in the general fund and not in the insurance assessment, in my opinion. But thank you for that information. And then the behavioral health policy.
But Representative, I do know though, they did approve recently at least several programs that are tobacco cessation and programs into the community. So I do know at least the board has done it. And I think this year they're also sending to appropriations their plan. So I can speak of currently what's going on, and I know that is a direct correlation to the health and policy. So I think that is what we're aiming to do. And I think that is the path for the board.
And I guess Rep Wood kind of said it best. Yes, it is for public health, but it is not insurance. And I think that's the delineating factor here is on the 1 year that we have now given them that money and the tobacco board has come up with programming, they don't have money for the second year. And again, it's about public health and not insurance. So I think there's just a fine line there that often gets commingled.
It's the population health and it's the benefactor. So it is reducing insurance costs off overall. So the money would be used to help benefit the population and then reduce primary care after that. I'm not the program expert, but I believe that's the logic behind it.
Yeah, I understand that. We could argue about this all day, but I can show you proof that money has not gone to that in the last 30 years, with the exception of 1 or 2 years. So again, I just think that it's a policy and it's not directly related to insurance. So that's okay. We can have that conversation afterwards. And the behavioral health policy position, can somebody elaborate on that, please?
Yes, so the staff also support the Transforming Children's Behavioral Health Policy and Planning Committee. OPM is tri-chair on that committee, and we also support the Children's Mental and Emotional Behavioral Health Plan Implementation Advisory Board. That's what the Behavioral Health Policy Oversight is referring to. Thank you.
Okay, so again, I think that's policy. And I don't know that there's a direct correlation to reduction or increase in insurance costs for that. Anything that I think is policy driven should be in the state budget and not be tacked onto, as Rep Wood said, a very small population of fully insured providers who already have a higher cost market than ERISA type plans. Then my last set of questions is for OHS. Was a little enlightening to see this information from the inception of this program at 700, from the staffing, just from the staffing perspective of $725,000 up to about 2 million is almost, 3 times the amount. 7 times 3 is 21. And that's happened in the last, not a lot of years because it's fairly new. The 39% being admin is concerning. because that means the majority of the dollars that are being spent on administration and not on the HIT or the benchmark or health equity or the certificate of need, which we know there's been a lot of problems with certificate of need. I've been very vocal about the fact that I think we do certificate of need shabby. Like, we don't go back and validate and stuff. It's 6% is a little concerning. I would like to know, it has been a main drive of OHS since when Vicki Veltri was here to increase the spend in primary care. According to your charts that were there, you're showing a good solid number right now, and you're looking to almost double it over the next few years. But I have asked in every meeting, and I have still yet to receive where you can show me the return on investment for that. Where if we are just going to pay primary care physicians more money, where am I going to see the savings? From specialist care, from hospital care, from chronic disease management. I still have not seen anything that shows me that this spend is anything more than just paying primary care providers more money and not actually reducing the cost of healthcare. So I've been here for 4 years. I've been asking that question for 4 years, and I still don't have that information, which makes me not want to be as willing to support the ask when it comes. And this has definitely had a massive growth in OHS. And I think we need to kind of have a little come to Jesus with, I'm an advocate of the healthcare benchmark tool. I don't think it's being used for all that it can be, or that it's actually helping drive down the cost of healthcare, which is your number one goal, when all we've seen since the inception of OHS, and they're not correlated, they're not the same, but all we've seen is the cost of healthcare increasing. And there's still not anybody telling me what we can do to bring it down. I've had ideas, I've talked to people about it and that, but it doesn't, it's all theoretical right now. And that's kind of annoying when you see the cost of an organization grow as exponentially as it has, with nothing that has come out that has given us the ability to control the cost of healthcare. So sorry if you can hear my dog. She's like coughing behind me. So again, I'm going to ask publicly one more time. I'm really looking for the ROI on this increased spend on primary care. And I'm hoping that it's more than just paying primary care physicians more money, because that does nothing except increase the cost of healthcare. I do have some concerns about OHS total dollar amount going into the cost of insurance. I think maybe we should look at these and break them down. And I would like to understand better what we're doing with the health info exchange. It's 32% of your total spend, and I'm not quite sure what benefit it's offering us right now. So I don't know necessarily that any of these are questions that can be answered today, unless you want to just high level address them and then get us the information going forward.
Yes, Representative Kim Martone, Chief of Staff. We will provide you a more thorough written response. At this point, just to address a few of your statements, I just want to clarify that 80% of the insurance funds are for Connie, for the Health Information Exchange, and the administrative section that you refer to, a huge bulk and significant part of our business office, which again, we're like 4 people, it's pretty small. Their time and effort goes into the HIE contracts, fiscal and monitoring of those contracts, as well as the fiscal analysis itself. So that's why you're seeing the numbers. But once again, in terms of staff and other expenses, the majority of the insurance funds are for the HIE. And we can definitely provide more of a descriptive effort and, for you in our next response.
Yeah, I'd like to understand that, because the breakdown that you put on the screen was 32% for the HIT, 14% for the benchmark, 9% for health equity, 6% for the CON process, and 39% for admin. So I don't know where the 80% is in there. So I'm seeing 32% based off of the pie grid that you put up.
Let me check. Okay. Right. Thank you. Yes, Representative, I think just to distinguish that between the personal services and the OE. So we do need to distinguish between the two. So there are about 8 staff members for the HIE that are in the personnel section for the insurance fund. And then the operating expenses that we have that you're referencing are also for that effort. And therefore, our consulting contracts, as you can see in the footnotes for Baylor, Mathematica, and that's for the benchmark, but we also have Connie and the APCD and the vendors that support the HIE. So if we can provide a further breakdown than that, please let me know, because we want to provide you all the information that you need.
Yeah, I would say then I'm an accountant, and if I'm confused, I guarantee you other people in the room are confused when looking at the pie graphs, right? So numbers are, I live, eat, and breathe numbers. So if you could make it in a more clear fashion of exactly what the money is that you guys are spending and how it's broken down, start from just the breakdown of support and then go into personnel and do a waterfall. But, you know, something that kind of makes more sense and the numbers tie out, I would appreciate it.
Sure.
Thank you, Madam Chair.
Thank you. Representative Walker.
Thank you, Madam Chair, and I want to thank everybody for their presentation today, even though we really haven't had a good enough time to really digest it. I think it's very important that we have the information ahead of time. And I've spoken about it, so I won't repeat it. But in trying to cross-reference the different documents and everything, it makes it very complex, because one of my biggest questions is, number one, you talked about, I think, the health exchange, and I see in here you have about $2 million that you added, you allot for DAS for services and IT. When the IT department in DAS was established, it was the reverse. They took money out of the different organizations and everything to cover the costs for their operations. And so here I see you are getting paid out of the insurance fund. So that's going to be something that I think I'm going to bring up with DAS to try and understand exactly how does that fit when we have a reversal of funding going in this circumstance. The other area that I got very confused about was DPH and OHS. I don't see where DPH starts and OHS ends, or vice versa. I will say, we just had DPH before us a day ago or 2 days ago for the CDBG, and we talked to them about some of their funding. And at that time, they said that 80% of their funding comes from grants. And to me, the grants also fall in the same category that my colleagues brought up about the tobacco fund. When we get funding for revenues for things to do in the state, the cost of operations comes out of that funding. So it doesn't mean that providing a person in OHS or in one of the other entities, that it comes out of the general fund. It should come from the total cost of the revenues that we are getting for those fundings. So I have a hard time trying to cross-reference that, but public health is supposed to, according to what we got the other day, sort of mirror what you said about what OHS's strategies were, and where it was controlling healthcare costs and growth. So I guess we've got to understand the beginning and the end of the two agencies and how they work for the state of Connecticut, because we don't want to pay for it twice. And many times we are seeing a lot of the same things. We're looking at asthma. And one of the issues that we were talking about was the issue of asthma and healthcare. And one of the issues, mental health care. And one of the issues that we talked about from DPH and DCF and DEMAS all talked about mental health. It seems like it goes across the board for every agency. So then what I worry about is who's in charge and who is managing the operations and who is really going in to do the scientific understandings of what we need here for families in Connecticut. So I would like to have a little bit deeper dive from you on how you and DPH work in tandem, and how the funding goes through DPH. Does it come to you? Is that part of the revenues that you are receiving, or is DPH assigning those people to your personnel area for specific areas that we were just talking about just now, mental health and asthma? And I think they had another one that I saw that was also duplicative. So if I had the opportunity, I think we would have had an understanding of where you all work in different areas. It's important that you do understand that this does go to the constituents of the state of Connecticut in their insurance plan. We should be, instead of having the increases that we have, we should be seeing a drastic improvement in the expense that goes to constituents since, I'd say, 2 years ago, because your main thrust was to address the cost to the people of Connecticut. We need to see how is that being covered in any of the activities or reports or anything that you are doing. That would be very helpful to me. And I think everybody else covered pretty much a lot of the same things. And it's not, I'm not trying to say that you don't have a value. I think you have, but I just want to make sure that your value is contained in the areas that is not covered by other agencies in the state of Connecticut. Thank you.
We can give that to you, Representative.
Any other questions from our panel? Sue Halpin?
Thank you very much. And thank you everyone for your presentations today. If I could, I'd like to make a general comment and then ask a couple of questions. I want to go back to how Chairwoman Wood framed the conversation at the beginning. This is one insurance fund, but it is funded by 4 different formulas. So different sections of the fund, the revenue comes from different entities. The conversation and the proposal that spurred this task force today was the result of a Senate Bill 372 that came out of the Appropriations Committee. And it focused on the assessment that funds the state agency portion of the insurance fund. And that state agency portion, when you add it all up, because you have to add up the line items separately, comes to around 50-something million. And that $50 million is funded by all insurers in the state based upon premium. So those are Eric's folks. So it's property casualty, auto, life, title insurers, a number of others, and also health insurers and accident policies. According to the fiscal note of that bill that ultimately turned into this task force, 79% of the agency portion of the bills is coming from health and accident policies, with 21% coming from those other insurers. If those other insurers were excluded from funding this funding mechanism, that would be another $3.5 million that would be added on to health and accident policies. And why is that important? It's important for a number of reasons. Only the fully insured members and policyholders can be assessed for this fund. So if you have 200,000 people who are still in the fully insured market, according to the latest numbers, and you have $3.5 million, 3.5 million people in the state, 200,000 are bearing the brunt of those costs. So you really have to look at it in perspective. And I think as we're struggling with this on the insurance side, you know, what is the public good, whether it's public health, tobacco funds, grant funds, et cetera, and who should bear that? Should it be spread the widest possible way, which would be the general fund, or should it be concentrated, you know, on these few members that are assessed through the mechanism that the Department of Insurance administers? So that's just one comment. Quick question for you, Sean. It's good to see you. And with full disclosure, I sit on the advisory council for the Office of Healthcare Advocate. Quick question for you. Does your office today handle behavioral health issues for constituents in the
healthcare insurance field?
Good to see you as well, Susan, and thank you for the question. We do handle behavioral health concerns on behalf of plan members, just as much as we help folks who have medical concerns. I don't know if the question is alluding to the Office of the Behavioral Health Advocate.
It is.
My understanding, the intent of that separate office is to address issues that come up between behavioral health providers and insurance plans when there are disputes over payments and things like that. We do get a fair number of questions from those providers, especially the smaller providers who are operating their own independent practice, or they just have a small group practice. They don't have the infrastructure, they don't have the administrative staff to handle some of these complicated issues over payment, over the contract provisions of their network provider agreements, things like that. They often reach out to us looking for a lifeline, looking for some help. We provide a little assistance, mostly just trying to connect them with somebody at the insurance company who can help them, because they often find that that's their biggest struggle, is just getting the attention of somebody who can help them resolve their issue. That's mostly as far as we go in most of those circumstances. Sometimes we're concerned about a potential conflict where, ironically, if we were to help the provider, would it somehow increase the cost of the patient that they're serving? So we want to stay away from those conflicts, and I think that's another reason why this separate office was created separately, so that they could deal with situations like that without as much of a conflict as we might find ourselves in those. It's rare, but it's a situation that can happen from time to time. I hope that answers your question.
It does, thank you. And again, I'll keep saying it, but that would only impact those 200,000 fully insured members in the state of Connecticut out of 3.5, roughly 3.5 million people in the state of Connecticut. Kim, it's wonderful to see you.
Nice to see
Thank you
Susan.
for your long years of state service. I know you've dedicated almost all of your career to state service. I have a couple questions for you, if you don't mind. OHS also receives a general fund allocation, is that correct?
That is correct.
So your total budget is around 17 million, is that
is
accurate?
correct. 17.7, yes.
Okay. And I guess I've always been under the impression that you received funding from a couple of different ways, that you received general fund dollars, you received insurance fund dollars. Do you also receive dollars from the hospitals? Is there a revenue source from the hospitals that pay for a certain portion of your budget?
Yes, we have a hospital assessment for the 27 acute care hospitals, and it's for the health systems planning unit of our agency, which is the certificate of need unit, state healthcare planning, and hospital reporting.
Okay. And any idea what amount that represents?
It's 4 million. Yes.
Okay, thank you. On page, well, the one that starts with fiscal year 2024 insurance fund and other expenses, you list Mathematica and Baylor Health as two of your major contracts, and those are entities that interact with the health insurers quite a bit.
Mhm.
Where would we see their costs reflected? Those contract costs reflected?
For the 9 million. Right? Yes, it's on the first line. It's part of the 9.2 million, the 88%.
Oh, okay.
Oh, no, I'm sorry.
Oh.
It's the health benchmark, right? Yeah, no, it's the health benchmark initiative. It's the 784, the 8%. Yeah, I'm sorry if we didn't footnote that correctly.
That's okay. So the 784,000 is
Yes.
essentially the Baylor contract. Is that accurate to say?
Yeah, it's both Baylor and Mathematica, but yes, essentially it is both of them together.
Okay. And do you break those folks out as the personnel or is that completely excluded?
No, that's excluded. Those are
Okay,
just consultants.
Okay. All right, thank you. There's also in the document, quite a number of references to transfer of SIM positions
Mhm.
from the SIM grant, which a number of us participated in for long
Right.
hours.
Yes.
Am I accurate in saying SIM is no longer active?
Correct. That grant ended a long time
Okay.
ago. The State Innovation Model Grant. Yes.
Okay, so are those positions, have they been repurposed? Have they been eliminated?
Um,
Or,
Yes, they've been repurposed. They're part of the Health Innovation Team, which has all the innovation strategies, which includes the cost growth benchmark, the primary care spend, the quality benchmarks, and so forth.
okay. And the HIE transfer,
Mhm.
that transferred from where?
The general fund to the
Okay.
insurance fund.
So was it under DSS at the time, or was it always under OHS and it just got transferred from fund to fund? The funding source just changed,
Yeah, my understanding was it was always OHS. It was
Okay.
just transferred.
but
to
the
a different
funding
fund.
source was changed from the general fund to the insurance fund.
Mhm.
Okay. Thank you very much. Appreciate it.
You're welcome.
Eric George.
Thank you. Thank you, Susan. Thank you all for your presentations. You did a very good job. And I want to start by saying, I believe that the work that you do is laudable. What I've said from the beginning is that these are so important, these agencies and the programs, that they should, and they are a benefit to the entire state of Connecticut. With that, they should be paid for and borne by the entire state of Connecticut, rather than what happened over many years, which is they were removed from the general fund to alleviate some burden on the general fund and place it on a smaller segment of payers. In this instance, it's the insurance industry. I wholeheartedly agree with Susan. This has had a direct impact of increasing insurance premiums. And for many, many years, I think understandably so, people have been focused on insurance overall, really laser focused on health insurance. It affects every single family, affects every single individual. And we're talking about the health and medical safety of individuals. But what we've seen recently is that other forms of insurance are not immune to premium increases. In the area of property and casualty with homeowners insurance, we have had drastic inflation. We have had litigation issues. We have had increased weather events, and we've seen insurance rates go up. Cost to build and repair homes have gone up. In auto insurance, the same thing, coupled with bad driving behavior, which has not alleviated since COVID ended. The point I'm trying to make is I fully support what you guys do. And I think that it should be borne by the greatest payer base possible. And that is the general fund. I'm also a realist, and I know that in one fell swoop, we aren't going to see everything that has been placed in the insurance fund that is not insurance department related since 1991 is going to automatically go into the general fund. I'm not, that does not get behind me. But from our perspective, there is no connection between what you do and auto insurance and life insurance and homeowners insurance. I am very sensitive to what Susan says, that if it's going to be borne by the insurance industry, well, let's keep that group as large as possible. But the largest group is the general fund and the taxpayer base. And when you start to shoehorn things like this, there's going to be strife. People are going to be saying this is unrelated to the products that we sell. I think that lawmakers, we talked about this last time, but I'm going to say it again. are have an understandable frustration about how can they reduce insurance premiums. In healthcare, you folks have dedicated so many man hours to trying to tackle how to reduce healthcare costs. We internally on the auto, home, and life side have spent time and worked with our policyholders to try to reduce those insurance costs. I'm going to point out that this is an area where policymakers, legislators, the governor's office, you have a direct impact on how much insurance costs. You can reduce that by putting this into the general fund. And Susan and I wouldn't fight anymore on this. But those are the points. I've made them in the past. I think your presentations were wonderful. I think what you do is great. I think that I should be paying for it as a taxpayer of the state of Connecticut. Thanks.
Any other questions? I do have just, I think a final comment. It seems like we're wrapping up here, that we are looking at, today's working group is on the insurance fund. I will also remind everyone that and additionally, the fully insured plans that are on the health insurance exchange also get additional assessment to fund the exchange. So I think what we're doing here today is trying to be responsible in terms of how we fund things, who's paying for what, and what services we can do to the best benefit of the constituents in Connecticut. That's our job as legislators. And in the end, we're responsible for the budget. So just applaud all the work that you do. Thank you for answering the questions. And we look forward to working with you as we move forward on this topic. Yep. Sue Halpin.
Thank you. For the next meeting, when we're discussing the immunization fund, and we'll have DPH in the room, I was wondering if we could also add to that discussion the other programs that are under the public health fee, which are those that are listed under the Department of Public Health portion of the insurance fund, which is inclusive of immunization services. And those two parts of that section are funded by two separate assessments. So I was wondering if we could combine the conversation on those two.
Yes, we can do DPH as a whole presentation similar to what we heard today. And then we can also specifically focus in on the immunization services, which we would ask OPM and DSS to also participate in that as well. Can we look at calendars and set a date? I would like to suggest 2 weeks from today, October 2nd, 10 a.m. Does that work? Or you can get back to me.
It doesn't work for me. I'm going to be out of state. Doesn't work for me. I'm going to be out of state. I will be back. I could either do the Monday or I could do Friday. I know people don't want to schedule on a Friday, but that's just me.
Monday the 30th. Monday the 30th.
I could do Monday the 30th. And I'm sorry. It's
Do you-
I don't want to just focus it on my schedule, but I won't be here.
Well, it's nice to have everybody at the table. We can just hold that date, Monday no. Okay, we will put a date out a few weeks from today and circulate it amongst the members of the working group. Any final thoughts or comments? The meeting is convened. Thank you, everybody. The meeting is adjourned.
Thank you.